So we begin with question number 188 of GT 185. So question number 188 was, which of the following condition causes megaloblastic anemia? And the options that were given to you were citrullinemia, orotic aciduria, maple syrup urine disease, and ornithine transcarbamylase deficiency. And the correct answer to this question is option number B, that is orotic aciduria. So option number B, orotic aciduria, is the correct answer to this question. Now we will briefly discuss about megaloblastic anemia. Well, megaloblastic anemia is a type of macrocytic anemia. And what do we mean by macrocytic? Macro means large, cytic means cell. So macrocytic means large cells. So megaloblastic anemia is a type of macrocytic anemia where apart from large cells there is also a defect in nuclear maturation, or there is a defect in DNA synthesis. So in macrocytic anemia, we define macrocytic when the size of the cell or the RBC, if the MCV is more than 100 femtoliter, then we say that it is a macrocytic anemia. And megaloblastic anemia is a type of macrocytic anemia. So, and in megaloblastic anemia, apart from large cells that we have already mentioned because it is a type of macrocytic anemia, there is also a defect in the nuclear maturation. So the nuclear maturation is behind the cytoplasmic maturity. So the nuclear maturation is immature relative to the cytoplasmic maturity. So when does megaloblastic anemia result? Megaloblastic anemia can result most commonly because of either vitamin B12 deficiency or folate deficiency, or it may also result because of certain drugs. Now, basically, megaloblastic anemia results due to lack of methyl tetrahydrofolate, which is a derivative of folic acid. But in that process of formation of methyl tetrahydrofolate, vitamin B12 acts as a coenzyme. Hence, deficiency of either of these vitamins may lead to development of megaloblastic anemia. Vitamin B12 deficiency may result because of intrinsic factor deficiency, which is important for the absorption of B12. It may result due to achlorhydria, which again interferes with the absorption of vitamin B12. It may also result in malabsorption syndromes like celiac disease, and it may also be seen in patients with chronic pancreatitis or patients with ileal resection. Most often, the deficiency resulting in megaloblastic anemia is seen in complete vegans who do not take any of the animal products and not even any dairy products. So this is the risk group where megaloblastic anemia is more commonly seen. And where does folate deficiency is commonly seen? Folate deficiency may result because of alcoholism, it may result due to deficient intake, it may result when the demand is high but the supply is poor, or it may also result in cases of malabsorption syndromes. There are certain drugs also which are known to result in megaloblastic anemia, and they are, the common ones are pyrimethamine, phenytoin, phenobarbital, (5-fluorouracil), and zidovudine. So these are the common drugs. If one is using them, they can also develop megaloblastic anemia. It has also been seen that whenever there is deficiency of any of these vitamins, then the manifestations are generally seen in rapidly dividing cells. So basically, manifestations can be seen in RBCs, and it can also has been seen to affect the GI tract. Hence, it may result in glossitis and other manifestations. And if you order a PS in case of a patient who has megaloblastic anemia, it is often that you will see pancytopenia, and along with that there would be hypersegmented neutrophils as well. So in the PS, in the CBC you will see pancytopenia, and in the PS you can see hypersegmented neutrophils, and apart from that large RBCs so you will see. And if you do a bone marrow, you will also see giant bands. So these will support your diagnosis of megaloblastic anemia. On bone marrow aspiration, you will see giant bands. In severe cases, when there is severe deficiency, there might be even CNS symptoms which may manifest in the form of psychosis and personality changes. In such cases, very high doses of supplementation would be required to cure the symptoms. So next we come to question number 189. And question number 189 was, a newborn presents with umbilical hernia. The condition is commonly associated with, and the options you had were Turner syndrome, congenital hypoparathyroidism, post-term delivery, and congenital hypothyroidism. And the correct answer to this question is option number D, congenital hypothyroidism. Well, congenital hypothyroidism is one of the most common endocrinal disorder that affects the newborns, and it has been seen that it has an incidence of close to 1 in 2500 to 1 in 4000 deliveries. So this is the incidence, and it basically results due to inadequate thyroid production, in which 80% of the cases result due to thyroid dysgenesis. So what are the signs and symptoms that you can see in a patient or in a neonate who is suspected to have congenital hypothyroidism? So in a patient who has congenital hypothyroidism, you will see that the child is usually lethargic, he has decreased activity, he may have a large anterior fontanelle, his cry may be poor, he may have macrocytic anemia, So hypothyroidism is also a cause of macrocytic anemia, where the RBCs are large, more than 100 femtoliters. Apart from that, in patients who have prolongation of physiological jaundice, even in those patients, we should suspect congenital hypothyroidism. Usually such patients are also chronically constipated. They may have a hoarse cry, and they may also be hypotonic. So these are the signs and symptoms in which one should suspect congenital hypothyroidism. So when you're examining such patients, what can you find? On examination of a child who is suspected to have congenital hypothyroidism, you may see that the child may have coarse clinical features. His tongue may be protruding out all the time. He may have macroglossia. Umbilical hernia is an important sign or examination sign that can be seen in a child with congenital hypothyroidism. His skin may be cool and mottled. And if you observe these children over a period of time, you will see that these children are behind their peers in achieving their developmental milestones. So they may present to you with developmental delay. As we had discussed, there would be macrocytic anemia, so these patients may often have pallor. And myxedema may also be seen. Rarely, they may also have goiter. So these are few important signs and symptoms and examination findings that you can see in a child with congenital hypothyroidism. So now we come on to question number 190. And question number 190 was, a 5-year-old child presents with vomiting and diarrhea for 2 days. Dehydration was corrected with intravenous fluids. Though the child is well hydrated now, he continues to have poor feeding and refusal of feeds. Weight of the baby is 18 kgs. How much fluids should this child get now? So the correct answer to this question is option number C, and how we have reached to this answer I will just explain. So the correct answer to question number 190 is option number C, 56 ml per hour. So basically we use a formula called the Holiday-Segar formula, which has been used here to calculate the fluid for this child. So this formula is called Holiday-Segar formula. This is also used to calculate the calorie requirement as well. And how do we calculate it? So we see he's a 5-year-old child and his weight is 18 kgs. So he is 18 kgs of weight. So now that his dehydration has been corrected, we have to give him maintenance fluids. And how do we calculate that? I will just show you. So in Holiday-Segar formula, they divide the weight. This child is 18 kgs. So they divide it in 10 and then subsequently 10. So this child is 18 kg, so it will be 10 and 8. So 10 and 8. So for the first 10 kg that the child, for the first 10 kgs of weight, the child will require 1000 ml per kg per day. So this would be 100 ml per kg per day. So this will come out to be 1000 ml per day. And for the next 10 kg, the requirement is 50 ml per kg per day. In this case, the weight of the child is 18. So for the first 10 kgs that he has, he will require 1000 ml, and for the next 8 kgs, he will require 8 into 50, that is 400 ml. So this is his requirement. Total that he would require will be 1400 ml in one day. So he would require 14,000 ml in 24 hours. And if you divide this, your answer will come out to be 56 ml in 1 hour. So this is how we calculate the fluid requirement for a child. So next we come on to the next question, and that is question number 191. And question number 191 was, bedwetting is considered normal in girls and boys till the age of, and the option that you had were 3 and 4 years respectively. Option number B, 4 and 5 years respectively. Option number C, 5 and 4 years respectively, and option number D, 4 and 3 years respectively. And the correct answer to this question is option number B, option number B, 4 years and 5 years respectively. So it has been seen that girls generally tend to mature earlier with regard to bladder and bowel control. So that is why there is a difference in the age. So bedwetting is, or nocturnal enuresis as it is called, results in complete evacuation of the bladder at inappropriate time and at inappropriate places. And by nocturnal enuresis we mean when it happens at night during the sleep. So this is basically unintentional passage or complete evacuation of the bladder at inappropriate places and at inappropriate time. While this can also be a symptom of any organic disease, many a times plain nocturnal enuresis is just a functional disorder. So there are various terms that are associated with nocturnal enuresis, and we will just discuss few of them. So primary enuresis results when the child has never been dry. So by primary we mean that he has always been incontinent and he has never been continent. So a child who has never established continence, and this comprises of almost 80% of the cases that one sees. So then comes secondary enuresis. So in cases of secondary enuresis, there has been a period of at least 6 months when the child has remained continent or when the child has not passed urine at inappropriate places like that. So that is secondary. By nocturnal enuresis we mean whenever this happens at night during sleep time. And in daytime wetting, this can even happen in the daytime. By monosymptomatic enuresis, we mean that when the child's condition is not complicated with any symptoms of lower UTI. So if the symptoms are just plain because nocturnal enuresis, when he does not have any other signs and symptoms of UTI, then it is called as monosymptomatic enuresis. And non-monosymptomatic enuresis, by this we mean when there are symptoms like UTI along with nocturnal enuresis. So these are the general terms that one should know with regard to nocturnal enuresis. So what are the treatment options that are available for nocturnal enuresis? So like I have mentioned, in most cases this is a functional problem. It is not a disease per se. No organic causes are found in almost 80% of such patients. So treatment options are also limited. The ones that are available and are often tried include motivational therapy. So we need to motivate the child, we need to tell him that there is nothing wrong with him. We need to tell the parents that they should not scold the child whenever he does something like this, and they should give him reward if he has been dry for a night. So that is what motivational therapy is. Apart from that, there can be bladder training as well. This is basically for younger children who sometimes delay voiding. So what happens is they have the bladder is full, they keep delaying it, and by the time they are ready to evacuate, there is dribbling or they become incontinent. So they need bladder training. So this is particularly for those children who keep on postponing voiding. So apart from that, there are other treatment options as well, which is Enuresis alarm. So in this, what happens is, we generally put an alarm and we wake up the child and we tell him that he should go and evacuate his bladder or empty his bladder. Apart from that, certain drugs have also been used, but their roles have not been clearly defined, but they can be used, and in fact if this comes as an option in any other question, you should be knowing what drugs are used for nocturnal enuresis. So these are imipramine, desipramine, and oral and intranasal desmopressin. Oxybutynin is also used, but this is particularly for those who have bladder voiding dysfunction. So oxybutynin is used for children who have bladder voiding dysfunction. So our next question is question number 192. And question number 192 was, a child aged 8 years presented with signs of increased intracranial tension. Imaging studies revealed a growth in the brain. What is the most common tumor in a child in the posterior fossa of head? So the correct answer to this question is option number A, and that is astrocytoma. So we should know that cerebellar astrocytomas are the most common posterior fossa tumors, and 50% of these arise from the midline and the remaining 50% from the cerebellar hemispheres. They are circumscribed, discrete and slow-growing lesions and are often associated with cysts within and around the tumor. The peak age of these tumors are between 5 to 13 years of age. So, astrocytoma was the correct answer to this question. So, next we come to question number 193. And question number 193, what is the early neonatal period? And the options you had were 6 days, 3 days, 10 days and 7 days. So the correct answer to this question is option number D, and that is 7 days. So we know that the neonatal period is from birth till 28 days of life, and the early neonatal period is from day 1 to less than 7 days or up till 7 days of life. So in this question, option number D is the most appropriate answer, and hence this is the correct answer. Option number D, that is 7 days. So next question is question number 194. Question number 194, it's an image-based MCQ, and you have to identify the disorder based on the features that have been given in the image. And the options that you had were Down syndrome, Klinefelter's syndrome, Turner syndrome and Marfan's syndrome. So you see that they are pointing towards the webbed neck and the widely spaced nipples. And so the correct answer to this question is option number C, and that is Turner's syndrome. So we know that the Turner syndrome is the most common cause of hypergonadotropic hypogonadism in girls. So this is the most common cause of hypergonadotropic hypogonadism in girls. And the most common karyotype which is associated with Turner syndrome is XO. Though there may be other mosaic karyotypes as well, but this is the most common karyotype that is associated with Turner's syndrome. And you can identify a child with Turner's syndrome at birth with few features. And what are these? So at birth you can see that the child may have lymphedema, he may have cystic hygroma, and there may be left-sided obstructive lesions, which are the common associated cardiac malformations with Turner's syndrome. So left-sided obstructive heart lesions. So in later life or in childhood, what are the common manifestations of Turner's syndrome? Well, in later life, these children often present with short stature. So many a times, girls, they present with short stature. So they may also present with signs of ovarian failure. So they may have delayed puberty as well. So these are the important signs of ovarian failure, which may manifest as delayed puberty. They may have high arched palate. Their nails may be hypoplastic. They may have a shield-like chest with widely spaced nipple. They have webbed neck. So because of the lymphedema in utero, this can cause a broad neck with a low or a distinct hairline. So they have a webbed neck. They have wide carrying angle or cubitus valgus as it is commonly known. This is one of the most common skeletal abnormality that is associated with Turner's syndrome. So a wide carrying angle or cubitus valgus, or an increased carrying angle. They would also be seen to have short fourth and fifth metacarpals and metatarsals. Though this does not have a clinical significance, but presence of this abnormality can help you in making a diagnosis of Turner's syndrome. Short fourth and fifth metacarpals and metatarsals. In the eye, you may also find ptosis, strabismus, and cataracts. Even scoliosis has been seen in 10%. And in renal anomalies, horseshoe kidney has been associated with Turner's syndrome. So these are the common manifestations of Turner syndrome, they can present with short stature, signs of ovarian failure. If you get a order ultrasound in such patients, their uterus may be small and the ovaries may be replaced with streak ovaries, as they are commonly called. They may have a high arched palate, nails may be hypoplastic, they will have a shield-like chest with widely spaced nipples, they will have a webbed neck, they will have an increased carrying angle or a cubitus valgus, they will have a short fourth and fifth metacarpal and metatarsals. In the eye, ptosis, strabismus and cataracts have been identified. Scoliosis may be seen in 10% of patients, and in renal anomalies, horseshoe kidney has been seen commonly in patients with Turner's syndrome. So next we come on to question number 195, and question number 195 was: a child aged 8 years is referred to you with a history of mononeuritis multiplex. Examination reveals hepatosplenomegaly. Examination of oral cavity and pharynx disclosed enlarged orange-colored tonsils. Which of the following statements is false with regard to the above condition? The options that you had were: it is a case of Tangier's disease, it is an autosomal recessive condition, the plasma LDL-C levels will be low, it is caused by ABCA1 deficiency. And the correct answer to this question is option number B, autosomal recessive disease. So Tangier's disease, as you would have made out from this question, then this is the condition of Tangier's disease, and it is an autosomal dominant condition and not autosomal recessive. So this was the false statement in the options that you were given to you. So this case is of Tangier's disease, which is a rare inherited disorder which has an autosomal dominant inheritance pattern. It is rare and it is also called hypo-alpha lipoproteinemia. It is characterized by severe reduction in the levels of HDL or the good cholesterol. Severe reduction in levels of HDL. It has been seen that the serum levels are less than 5 milligram per deciliter. And it has also been seen that it is associated with increased catabolism of HDL. So basically there is a reduction in the levels of HDL. It is characterized by, these are the important characteristics: orange tonsils. So this was the clue in this question: orange tonsils, peripheral neuropathy, hepatosplenomegaly, and discoloration of the rectal mucosa. Most of these conditions result due to the deposition of cholesterol. So these are the characteristic features which help you to make a diagnosis of Tangier's disease. So apart from low levels of HDL, it has also been seen that the levels of ApoA1 and HDL are low, while the levels of LDL and triglycerides are increased. The condition has no specific treatment. So this was about Tangier's disease, an autosomal dominant condition. So we come on to the next question, and that is question number 196. And question number 196 was: neuroblastoma differs from Wilms tumor in all statements except, and the options that you had were: associated with opsoclonus myoclonus syndrome, crosses the midline, more malignant, found in children. Now the correct answer to this question is option number D, and that is found in children. And why this is the correct answer? Because they were asking you about the factor which differentiates neuroblastoma from Wilms tumor. And found in children is not the differentiating factor because both are seen in children. So that is why this is the correct option. So what are the common differences between neuroblastoma and Wilms tumor? Well, as the options suggest, neuroblastoma is associated with opsoclonus myoclonus syndrome. And Wilms tumor is associated with WAGR syndrome and Beckwith-Widman syndrome. So neuroblastoma may cross midline, and usually Wilms tumor does not crosses midline. Usually neuroblastomas are fixed and immobile, while Wilms tumor may be displaced. Constitutional symptoms are common in case of neuroblastoma. While constitutional symptoms are not so common with Wilms tumor. So these are the differentiating factors of neuroblastoma and Wilms tumor. So now we come on to question number 197. You monitor a baby with shock with the following parameters except. And the options that you had were urine output, pupillary reaction, sensorium and capillary refill time. And the correct answer to this question is option number B, pupillary reaction. So when the child is in shock, his renal perfusion will be deranged. So he will have a decreased urine output. His cerebral hypoperfusion will result in altered sensorium. And because of generalized hypoperfusion, the child will have a delayed capillary refill time. So when we are resuscitating a patient or when we are assessing the status of a patient in shock, urine output, sensorium and capillary refill time will help us in assessing the status. But the pupillary reaction will not. In fact, pupillary reaction is checked or helps in assessing the status of a child with CNS hemorrhage or impending herniation. So a child who has unequal pupillary reaction or unequal pupillary size may be having an impending herniation. Or a child with pinpoint pupils may reflect or may suggest a pontine hemorrhage, but it will not reflect the status of a child with shock. So next we come on to question number 198. And question number 198 was, in which of the following flag sign is seen? And the options that you had were kwashiorkor, marasmus, pellagra and hypothyroidism. And the correct answer to this question is option number A, kwashiorkor. So what happens in kwashiorkor? Because because of lack of energy or lack of nutrients, the hair in a child with kwashiorkor become dull, lusterless, and they are easily pluckable. And they have no sheen at all. And they would become reddish in color. However, there are periods when the nutrition of the child would be adequate. During that time, the color of the hair would become normal. So this is why this sign is called a flag sign. There are alternate bands of normal pigmentation and dyspigmented hair which reflect periods of normal nutrition and lesser nutrition, during which this less pigmented hair has occurred. So this sign, flag sign, is seen in kwashiorkor. Next we come on to question number 199, and question number 199 was, for the following question there is an assertion and reason statement. Mark the correct option as per the following direction. Select one of the following. A 5-month-old infant is brought with tuberous sclerosis, is diagnosed to have West syndrome. Assertion. The condition is characterized by a combination of Salam spells, mental retardation and hypsarrhythmia. Reason. The patient could respond well to ACTH and corticosteroids. Which among the following is correct? And the correct answer to this question is question number B, which says both assertion and reason are true, but reason is not the correct explanation for the assertion. So option number B, both assertion and reason are true, but reason is not the correct explanation of assertion. So we see here there is a child who is 5-month-old who has Salam spells, mental retardation and hypsarrhythmia. So we see that this child has infantile spasms, and the most common cause of infantile spasms are metabolic disorders, tuberous sclerosis and hypoxic ischemic encephalopathy. Usually a patient with infantile spasm responds well to ACTH and corticosteroids therapy, but of late vigabatrin has also been tried and it has been seen to show good results in patients with infantile spasms in patients with tuberous sclerosis. So vigabatrin is showing promising results in patients of tuberous sclerosis who present with infantile spasms. We now come on to the next question, and that is question number 200, which is again an image based question, and it says a 16-month-old child was brought to pediatric emergency with history of intermittent short duration GTCS since the last 2 days. He had a past history of seizures starting 6 months of age and is currently on sodium valproate. History revealed global delay in milestones. His anterior fontanelle was normal and skull sutures were widely separated. The brain imaging performed upon stabilization of the child is shown below. What is your diagnosis? And the options that you had were schizencephaly, holoprosencephaly, porencephaly and lysencephaly. And the correct answer to this question is option number A, schizencephaly. So this image is characteristic of schizencephaly, where if you see clearly, you see that there is a loss of brain damage, brain tissue in the right temporal region with a large CSF filled cleft. This is characteristic of schizencephaly, and it is an uncommon neuronal migration defect that manifests as gray matter lined cleft in the brain parenchyma, which extends from the ependymoma to the pia mater, dividing the brain into two parts, the one ahead and the other behind the cleft. So here schizencephaly is the correct answer, which is a rare neuronal defect, neuronal migration defect. Which is characterized by CSF filled cleft, which are lined by gray matter. So this image was of schizencephaly. Next we come on to question number 201, and question number 201 was, a newborn is noted to be quite jaundiced at 3 days of life. Laboratory data demonstrate that his total bilirubin to be 17.8 milligram per deciliter and direct bilirubin of 0.3 milligram per deciliter. Which of the following factors is associated with an increased risk of neurological damage in a jaundiced newborn? So here we see that the child is 3 days of age and his levels are high and his direct bilirubin is less. So this is indirect bilirubin, and he would be requiring treatment for this, either phototherapy or exchange transfusion, so that he does not land up in kernicterus. And the options that we had were metabolic alkalosis, increased attachment of bilirubin to binding sites caused by drugs such as sulfixazole, maternal ingestion of phenobarbital during pregnancy, and D, neonatal sepsis. And the correct answer to this question is option number D, neonatal sepsis. So they were asking you about the condition which will result in worsening of or which will make it easy for the bilirubin to cross the blood-brain barrier, and this answer is neonatal sepsis, because the first option that was given to you was metabolic alkalosis. Actually it is metabolic acidosis which facilitates the bilirubin crossing the blood-brain barrier and causing CNS encephalopathy. Similarly, in case of option B, sulfixazole and other drugs compete with the bilirubin for the binding sites on albumin, and they actually displace it from the albumin, but they do not facilitate per se the entry of bilirubin into the or crossing the blood-brain barrier. In option number 3, actually phenobarbital or phenobarbital helps in the maturation of glucuronide transferase enzyme. Hence, this is also not the correct answer. So the correct answer to this question is option number D, or neonatal sepsis. Next we come on to question number 202, which says, a 10-month-old infant has dysplastic right external ear, some preauricular tags and a small notch coloboma in the iris and the lower lid. Which condition does he is likely to have? And the options that you had were Vater association, neurofibromatosis type 1, retinoic embryopathy, or option number D, charge association. And the correct answer to this question is option number D, option number D, charge association. So in charge association, it is a mnemonic that stands for coloboma of iris in the eyelid, heart anomalies, atresia choanae or choanal atresia, retarded growth, genital anomalies, and ear anomalies. So this is about the charge association. It is associated with coloboma of the iris or the eyelids, heart anomalies, atresia choanae, retarded growth, genital anomalies, and ear anomalies. In Vater, what you see is vertebral anomalies, anal atresia, tracheoesophageal fistula, eye or ear anomalies, and renal anomalies. So the correct answer to this question is charge association, that is option number D.